Welcome to the Partner Education Conversation Series, featuring information and insights from E&A's industry partners on topics of importance to emergency nurses. Today's episode focuses on patients in the ED presenting with mild head injuries and what ED nurses need to know as they diagnose, treat, and help patients with their road to recovery. To do that, joining me is Patrick Kiley, the Vice President of Clinical Operations with BrainScope. Patrick, welcome.
Hey, Dan, thanks so much for having me. I'm really excited to be here. We appreciate the partnership.
Absolutely. Patrick, let's just start off with a little bit of your background in healthcare.
I appreciate the question because my background in healthcare is not what a lot of people think is going to happen when you get into nursing school. I went into nursing school thinking that one day I was going to be a chief nursing officer. Still could happen, right? But I worked in critical care in Philadelphia. I was a trauma surgery ICU nurse and a cardiovascular ICU nurse at two major teaching institutions. And I got recruited to work in medical device implementation and education. Crazy to think about it, 10 years ago.
Wow.
And it was a different facet of nursing that I didn't even know existed. And how amazing is it that nurses who are at the forefront of delivering patient care and are the ones actually putting their hands on so many different types of technologies going into the hospital, especially in emergency rooms and ICUs, are also being a part of the decision-making processes that happen within these med tech companies to make sure that the voices of nurses are being heard. And I share this inkling of my story with everyone because when I was, everyone says, "Oh, you're making the jump. You're going to the quote unquote dark side." It's been really bright for me. It's been a really amazing adventure. I've taught people how to do CRRT in Haiti. I've gone over to Germany and Thailand, and it's been really incredible. My mentor, who's a CNO of the health system now, said to me, if you remember why you got into healthcare in the very beginning, which is patient care, and you put them at the forefront of everything that you do, everything else will fall in line. And, that's been something that's stuck with me. And it's why I am here with BrainScope today. So thanks so much.
Ultimately, it comes down to patient care and this opportunity that you have to work with E&A and other partners that are helping prepare the frontline folks to do the best that they can do. Obviously, that expands your ability to have an influence over what's happening and delivering the best care possible. So we're talking about mild head injuries, and certainly that's something that a lot of people can relate to when it involves going to the emergency department. Tell me a little bit about, from your perspective, your experience, the frequency in which these do appear in the ED, and maybe more importantly, what are some of the most common reasons why these appear in the ED? Because there may be some folks that go, "I've never seen a mild head injury, but I've seen a patient come in with a sledding accident situation, which probably was a mild head injury." But talk a little bit about the frequency and some of the most common reasons why they appear with those symptoms.
The idea of head injury, I think for a lot of individuals, even healthcare workers, right, is that sometimes we get lost in this, a patient needed to have hit their head in order for there to be a head injury, which we know now because of so many advancements around mTBI, i.e. concussion, that just isn't the case, right? The brain, as it moves back and forth and experiences, we'll just call it a blow of some sort, right, gets bruised, to put it easily. And when you have that type of back and forth movement, either from a car accident, a sledding accident, as you mentioned, sports, the list goes on. Very common, we hear about falls. Of course, when it's nicer outside, we get more activity going on, or even in the snow with ski injuries. They're happening every single day. When we think about mild traumatic brain injury, right, we're looking at roughly 7 million head injuries occurring every year. And about 95% of those are mild traumatic brain injury. And when you look at other statistics that are out there, you've got 5 million of those patients going to the ED and roughly 4 million getting head CTs, and about 91% of those patients are head CT negative. When you look at the landscape of the emergency room and the patients that are coming into the emergency room, those numbers are a fraction of the overall patients that are coming in through the ED, right?
Sure.
Maybe 2%. When you look at how long those patients are waiting in the emergency room for head CT, when a patient is on the cusp of, hey, do they need this? Do they not need this? And not to mention, they're going in for information, right? About why do I feel the way that I feel?
Sure.
And you and I both know that right now, the way that it is, yes, we can say with CAT scan, they don't have a brain bleed. There's nothing to show that these patients have any type of cognitive impairment, and a concussion just can't be graded as it is today.
What, in your experience with BrainScope, are you guys hearing from ED nurses about how they want to be better prepared for those types of situations? Because there's a lot of strain and stress on EDs, staffing wise,
Yeah.
boarding, wait times. There's a lot of external factors that are impacting their ability to do some of what you just described. So what are you hearing, what is BrainScope hearing from ED nurses about what could help them in terms of what they actually need to navigate that first critical stage, which is understanding how to, not let that person linger in those critical times because they're waiting for one thing or another, or they're deep in the list of priorities of people who are triaged in.
Yeah. So, Dan, that's a really, really good question. And it is perfect into what the value proposition of a technology like BrainScope is. And when I think about why I do what I do and my team does what we do, it's patients and then our healthcare workers, right? And one of the most profound articles that I've read this year was published in the Journal of Emergency Nursing, and it was all about rethinking traditional emergency department care models. And quite honestly, that's what we're doing, right? So, let me take a few steps back. What are we hearing from nurses? We're hearing from nurses there aren't enough of us. We're hearing from nurses, oh, I have to do one more thing when it comes to patient care because so many projects were put on hold during COVID, and then all of a sudden we come back and things are opening and all of these projects want to happen. We're hearing from nurses, there's too many patients, or the patient boarding numbers are at an all-time high. Everybody held off on coming into the emergency room when COVID was at its highest, and people were most afraid of coming in for whatever other instance of injury they had going on within their person. So now, we have this influx. So we don't have enough staff. We have too many patients, and there's too much that we have to do and we have to put on our plate. So when we're thinking about how we fit into that, the beautiful thing about BrainScope, and just a little background on BrainScope. BrainScope is the first and only non-invasive FDA cleared device to objectively assess mild traumatic brain injury, focusing right now on brain bleed and concussion. One of the reasons that this technology really got my attention is because myself, as a former nursing leader in the hospital, and then just doing what I've done for the last 10 years in medical device implementation and training new technologies, is the fact that, as long as we are in line with state regulations and the hospital regulations around policy and procedure of who can run this test, when we think about rethinking that ED landscape and getting more individuals taking some of the burden off of the nurse's responsibilities, that is one of the key components of this device. It is intuitive, it is easy to use. The training around the device is something that my team is really, really focused on. And we have all of the resources there, and we create these core group of super users, and they can be paramedics. They can be emergency department technicians. They can be ancillary staff if it works in terms of actually performing that test. And we've even had interest from a respiratory therapist group at one hospital looking to be able to do this so that the nurses can spend more time doing the things that they need to be doing with the patient. And this test, which not only helps improve overall ED throughput and efficiency, can also take off some of the burden of their workflow as well.
You mentioned throughput and efficiency, and really what you've described, it sounds like to me, is getting that initial triaged diagnosis, understanding of what this patient is really experiencing, because that just sets the course of care from that point on. Given that, talk a little bit about what this does to help set that course of care, because it's the triage is always the most important part of this to understand what happens next, but there's also the care that continues while in the ED and ultimately what those discharge instructions can look like. So this sets the course for helping that patient, get the most out of their visit to the ED, but also what to do post visit to the ED, right?
Yeah. So I brought up a little while ago about how mTBI patients make up about 2% of the ED visits. It's really what the large scale impact is of those patients that starts with the triage process, right? I learned very quickly. As I said to you before, I was an ICU nurse. I always said one hospital is one hospital. Now I've learned even more that one emergency department is one emergency department. But every emergency department, right, has some type of triage process set up. They might be different. And then how do we incorporate into that particular process and that flow. And what I really love telling stories to go along with this. So I'll give you an example of how we work within any clinical workflow to help decrease ED overall length of stay, improve efficiency, and improving patient and staff satisfaction along the way. And the data is there to prove that. We have the opportunity to say, okay, hospital X, hospital ENA, we are coming in and we're going to work with you and your clinical staff. Walk us through a day in the life of, right? A patient comes in with an mTBI. They have a GCS of 15. They're between 18 and 85 years old. They were drinking a couple drinks last night. They're only mildly impaired from alcohol. And oh, yes. And by the way, they have something that required them to be on blood thinners. Well, we work in all of those states, right? So that's a first and foremost. And then we can identify and say, hey, does this patient fit within a decision support tool that we currently have to help rule out the need for a head CT or rule in the need for a head CT? And what about that middle ground, right? And that's where we come into play with creating a new care pathway and saying that as part of that triage process, we were able to identify patients at a large academic medical system and say, okay, so now from this patient decision support tool, patient, you're going to go and you're going to receive a BrainScope instead of waiting in our certain institutions. This institution was pretty good. They fell within national averages of CT wait time, which are around 2.5 hours, which is still too long for some of these patients.
Yeah.
And, we've heard up to 6 to 8 hours at ENA and ASAP. That's some of the wait times that are out there right now. And this test on average is being completed from start to finish within 14 minutes. And patients are getting a printout of, you are BrainScope negative. There's no reason for you to wait here. They're going through an RME at this particular hospital. The physician is seeing them and saying, you're good to go. And patients are leaving the ED in under an hour. The fastest was 41 minutes from start to finish. And we know that, that's one scenario. We have multiple. One of our larger health systems out in California presented a poster on this, and they actually saw within this patient population a 58% improvement in their overall length of stay with this patient population from 6 hours down to 2.5 hours overall, which is a really, really big improvement. So, from the idea of where do we fit into the equation, our tool specifically says mTBI triage, and that's what we have the opportunity to do. And when we run that test, the patients are really benefiting because it's not just your CT negative, goodbye, there's nothing else that we can give. We also have a functional injury assessment, and the lower that score, the higher the probability is of a brain impairment like concussion. And we also have patient instruction tools, and there's plenty of research to show that with proper discharge and education, patients will do what they have to do to make sure that they're compliant and seeking the help that they need to within mTBI treatment, recovery, and so on. So really exciting times and really exciting opportunity.
creates a very cohesive sort of approach to it that impacts a number of different areas, within the ED for the patient, and ultimately, when you talk about efficiency and moving things in a way that benefits the patient but helps to keep the flow of the ED going. When nurses are dealing with staff size, they're dealing with boarding because of the complexity of other acute care that they're providing. It sounds like there's a lot of benefits through all that. I know just from the little bit of time that we've been together, you could talk about this, extensively, both from the perspective as a caregiver, someone who has been in the hospital environment, but also from your role with BrainScope. We only have so much time here, but there is an opportunity for folks who are listening to learn more about what BrainScope is doing in terms of mTBI, coming up in a webinar in a couple of weeks, right?
Yeah, that's right. So on November 14th, you're going to be hearing from yours truly and my colleague Dave Steiner. Dave Steiner is an emergency nurse, trained in the military, does flight nursing. He's been through it. And together, we both have history with mTBIs and concussions, and it's really important. It hits home for both of us, and concussion starts in the ED, and that's what this webinar is really about. Because in a world where we are inundated with patients, we are inundated with the care that we have to give. The patients at the end of the day are the ones that sometimes are not benefiting, right? They're actually the ones that are not seeing what the full gamut is in terms of technologies. And we have the opportunity to do that with a tool that's been uniquely suited for head injury assessment, right? It's a point of care assessment. You heard that it can be done in, on average, 14 minutes. And we've done that just when people say, well, how does this work? Right? We have basically been able, just like an EKG can say, hey, what heart rhythm is this patient is? We've been able to look at brain waves utilizing quantitative EEG to give those outputs of where if there's a brain bleed or brain function impairment. So really exciting stuff. And that's what you'll learn more about on November 14th.
And folks can take a look at ENA social media. We'll have more information about where to register and when, all the other particulars about when, where, and what they can expect with the webinar in a couple of weeks. Patrick, Kiley from BrainScope, appreciate you being a part of the Partner Education Conversation Series today.
Thanks, Dan. It was so nice meeting you. I really appreciate everything that you and your team do. And thanks to all of our emergency nurses out there. You are so, so important and so appreciated.
That'll do it for this episode of the ENA Partner Education Conversation Series. To find future episodes or to listen to this one again, visit ena.org/ENAU and click on the Partner Education portal.